Welcome to our deep dive into prostate cancer diagnosis and management in the UK. You've given us some really interesting guidelines and research reports from leading organizations like GIRFT and NHS England. We're going to take a close look at all of it today and try to distill it down to the most important takeaways.
It is really fascinating to see how these guidelines reflect a real evolution in thinking, moving away from that one-size-fits-all approach and really starting to emphasize these more personalized care pathways.
Yeah, absolutely. Let's start with this idea of a changing landscape then. What really jumped out at me when I was looking at the GRFT guide was this strong emphasis that they put on multidisciplinary teams and the importance of early diagnosis. Why is that such a crucial element in this new approach?
Well, timely diagnosis is absolutely essential. I mean, delays can lead to disease progression and then potentially limit those treatment options down the line. But it's not just about diagnosing quickly. The multidisciplinary approach is so important because it ensures that you have experts from all of the relevant fields involved. So from urology to radiology to oncology, all of those experts collaborate to develop the best possible care plan for each patient.
So you're really talking about getting the right people in the room at the right time. And that makes me think about those new faster diagnosis standards that were implemented in October 2023. Can you unpack what those standards mean for patients just in practical terms?
Sure. So these standards represent a really significant push to streamline the entire diagnostic process. And they do that by actually setting specific timeframes for those key stages. So for example, now there's 28 days from referral to diagnosis, 62 days from referral to the first treatment, and 31 days from the decision to treat to actually starting treatment.
So some pretty tight targets there.
Yeah. They really aim to significantly reduce waiting times, and that, of course, can lead to faster diagnosis and faster initiation of treatment, which is what we want.
Yeah, that speed can make a world of difference for the patient, both in terms of their peace of mind, but also ultimately we hope their clinical outcome as well.
Yeah.
Now let's move on and talk about something that I know has generated a lot of discussion over the years, and that is PSA testing. These guidelines highlight a pretty significant change in the approach to PSA thresholds, don't they?
Yeah, absolutely. There has been a lot of debate, but these guidelines recommend moving away from those age-stratified PSA thresholds to a single threshold of 3 nanograms per milliliter for men aged 50 to 69, regardless of whether or not they have symptoms.
Wow, so really trying to simplify things.
Exactly. And this shift is really based on recent research, particularly the rapid pathway analysis, which showed that those age-related cutoffs were actually missing diagnoses in a significant number of men.
And I imagine particularly in those younger men who might fall into those thresholds previously.
Exactly. And early detection, as we said, is key. These guidelines also acknowledge that certain groups like Black men are at higher risk, and they actually recommend an even earlier screening age of 45 for that group.
That's really important for our listeners to remember that if you're in that category, it's a conversation you definitely need to be having with your GP. Now, another area where these guidelines recommend a significant shift is in the use of MRI. It seems like pre-biopsy MRI is really moving from a maybe to a must-have.
Yeah. The GRFT guide really emphasizes the importance of pre-biopsy multiparametric MRI, or MP-MRI as it's known. It can really be a game changer. Studies have shown that using MP-MRI can safely reduce the number of unnecessary biopsies by as much as 25%. And in some cases, it can even help avoid a biopsy altogether.
That's a remarkable impact, not just in terms of cost savings, but also reducing patient anxiety and discomfort. So the MRI is acting as a kind of filter, helping to determine who really needs biopsy and who doesn't.
Exactly. And it's not just about reducing unnecessary biopsies. MRI also helps to target those biopsies more precisely. So if the MRI reveals any suspicious areas, the biopsy can be directed specifically to those areas, making the procedure more accurate and efficient.
It sounds like it's improving the diagnostic process on multiple levels. But what happens in those cases where the MRI results aren't completely clear? I noticed the guide mentioned something called PSA density. How does that factor into the decision-making process?
PSA density is a valuable tool when the MRI findings are equivocal, and it's calculated by dividing the PSA level by the prostate volume, which is measured on the MRI. So a high PSA density, even with an unclear MRI, may still warrant a biopsy.
So it's another piece of information that helps doctors make a more informed decision about whether or not to proceed.
Precisely. It adds another layer of analysis and helps personalize that diagnostic pathway for each patient.
Speaking of biopsies, I know that word itself can be a little bit intimidating to a lot of people.
Yeah.
What are these guidelines doing to address those concerns and make the whole process less invasive and more patient-friendly?
Well, the standard approach now is local anesthetic transperineal biopsy, or LATP. This technique is less invasive than the traditional methods and can often be done in an outpatient setting, which means potentially shorter hospital stays and faster recovery times for the patient.
I imagine that makes a big difference to the patient experience. And as we've already talked about, the biopsy procedure itself has become more targeted and efficient, thanks to that use of MRI as well.
Absolutely. Instead of doing random sampling, biopsies are now planned very strategically, targeting those specific areas identified on the MRI. And this targeted approach not only reduces unnecessary sampling, but also increases the accuracy of the biopsy, leading to more reliable diagnostic results.
So we've seen a real shift towards this more refined and less invasive approach to both PSA testing and biopsies. But what happens next? What are the next steps once a diagnosis of prostate cancer is actually made? And how are these guidelines shaping treatment decisions? We'll delve into that in part 2 of our deep dives.
Welcome back to our deep dive into the evolving world of prostate cancer diagnosis and management in the UK.
We've already uncovered some really interesting shifts in the approach to diagnosis, particularly with that emphasis on personalized care pathways and the use of MRI and those new, faster diagnosis standards. But obviously, a diagnosis is really just the beginning of the journey. So let's talk about what happens next and how these guidelines are influencing treatment decisions.
One of the most striking things, I think, when you look at these guidelines is the focus on active surveillance as a primary management strategy for a certain group of patients. It's really a departure from that treat at all costs mentality that I think prevailed for quite a while.
Yeah, I'm really curious about this approach. What is the rationale behind recommending active surveillance? And what types of patients are even considered good candidates for this strategy?
So active surveillance is recommended for men who are diagnosed with lower risk prostate cancer, and specifically those who fall into those categories 1 and 2 of the Cambridge Prognostic Group or CPG system. So that basically means men with a Gleason score of 6 or less, a PSA level below 10 nanograms per milliliter, and cancer that appears to be confined to the prostate gland itself. And the thinking behind active surveillance is that for these lower risk cancers, the potential harms of immediate treatment, like side effects like incontinence or erectile dysfunction, might actually outweigh the benefits.
So it's about carefully weighing those risks and benefits and recognizing that sometimes the best course of action is to watch and wait rather than rushing into those potentially aggressive treatments.
Yeah.
But I noticed they use the term active surveillance, so it's not simply a case of ignoring the cancer. What does monitoring look like for patients on this pathway?
It's a very proactive approach.
Yeah.
The GIRFT guidelines actually recommend quite a rigorous monitoring schedule, especially in that first year after diagnosis. So patients typically undergo PSA testing every 3 months, and they have a repeat MRI at that 1-year mark. And then the frequency of monitoring may be adjusted over time depending on that individual's risk profile and how the cancer is behaving. It's all about keeping a close eye on things and being prepared to intervene if there are any signs of progression.
That makes sense. It's reassuring to know that even though treatment might not be immediate, there's a very structured monitoring process in place to ensure that any changes are picked up early. But what happens if the cancer does start to show signs of progression during that active surveillance? What are the next steps then?
That's when the conversation shifts towards those more active treatment options, and the guidelines highlight several possibilities, including surgery, radiotherapy, and hormone therapy. And the choice of which treatment really depends on various factors, including the stage and grade of the cancer, the patient's overall health and personal preferences, and of course, the expert opinion from that multidisciplinary team we talked about earlier. It's about having a very frank and open conversation between the patient and the clinical team to decide on the best course of action.
So even when active surveillance is that initial approach, there's a clear plan in place for what to do if the situation changes. Let's break down those treatment options a bit further. Starting with surgery. What does surgical intervention for prostate cancer typically entail?
So the standard surgical procedure for prostate cancer is a radical prostatectomy, which involves removing the entire prostate gland. There are different surgical approaches, each with its own set of benefits and risks, and advancements in surgical techniques are being made all the time. Robotic-assisted surgery, for example, has become increasingly popular in recent years because it allows for greater precision and potentially faster recovery times.
So it sounds like surgical techniques are evolving to become less invasive and more precise. What about radiotherapy? What does that involve? And how does it differ from surgery?
So radiotherapy uses high-energy rays to target and destroy those cancer cells. There are 2 main types: external beam radiation, which is where the radiation is delivered from a machine outside of the body, and then brachytherapy, where radioactive seeds are actually implanted directly into the prostate gland. And the choice of which type of radiotherapy to use and the specific dosage and duration is very much determined by the individual characteristics of the cancer and the patient's overall health.
And how does hormone therapy fit into the treatment picture for prostate cancer? I know it's often used in conjunction with other treatments.
Yeah, so hormone therapy works by reducing the levels of male hormones in the body, particularly testosterone, which can fuel the growth of those prostate cancer cells. And it can be used as a standalone treatment for some men, particularly those with advanced prostate cancer. But it's often used in combination with surgery or radiotherapy to enhance their effectiveness. The idea is to attack the cancer from multiple angles to improve the chances of successful treatment.
So it's clear that the treatment options for prostate cancer have become increasingly sophisticated and diverse. But with all these options available, how do doctors ultimately decide which approach is best for a particular patient? It seems like there are a lot of factors to consider.
Absolutely. It's not a one-size-fits-all situation at all. And these guidelines strongly advocate for shared decision-making between the patient and the clinical team. It's about taking all those individual factors into account. So the stage and grade of the cancer, the patient's overall health, their personal preferences, and the potential risks and benefits of each treatment, and arriving at a decision that feels right for that particular patient.
So that emphasis on shared decision-making, I think, is a really positive development. It puts the patient right at the center of their own care and empowers them to really actively participate in that decision-making process. It's not just about following a protocol, it's about finding the best path forward for that individual.
Exactly. It's about recognizing that each patient's journey is unique and requires that personalized approach.
Hmm.
And that brings us to another really crucial aspect highlighted in the guidelines, monitoring after treatment. It's not just a case of job done once that initial treatment is complete, is it?
Absolutely not. Monitoring after treatment is so vital to ensure that the cancer hasn't returned and to manage any potential long-term effects of that treatment. So can you talk a little bit about what that monitoring process looks like?
So, post-treatment monitoring typically involves regular PSA testing to track those PSA levels over time. And the frequency of those tests depends on the type of treatment they received and the individual's risk factors. So, for those who've had radical treatment like surgery or radiotherapy, PSA tests are usually done every 6 months for the first 2 years, and then annually if the PSA remains undetectable.
And if the PSA starts to rise again, what does that indicate?
A rising PSA level could be a sign that the cancer has recurred, and further investigation will be needed to confirm that and determine the best course of action. The earlier a recurrence is detected, the more treatment options are available, so regular monitoring really is key.
The GIRFT guide also mentions this increasing use of electronic PSA tracking. How does technology fit into the monitoring process, and what are the potential benefits for patients?
So electronic PSA tracking involves using digital platforms to record and monitor those PSA levels over time. And this allows for more efficient tracking of PSA trends, making it easier to spot any concerning changes. It can also streamline the whole monitoring process, reducing the need for unnecessary clinic visits. Some platforms even allow for remote monitoring where patients can report their PSA results from home, which is incredibly convenient and can reduce anxiety for many patients.
It seems like technology is playing an increasingly important role in prostate cancer care, from aiding in diagnosis to streamlining treatment to making monitoring more efficient and patient-friendly.
Absolutely. And this really aligns with that broader trend towards more personalized and patient-centered healthcare delivery. The goal is to really empower those patients and give them more control over their own care journey.
These insights have been incredibly valuable. We've covered a lot of ground, from initial diagnosis to the complexities of the treatment options to the crucial role of monitoring. But before we move on to part 3, I want to touch on a point the GRFT guide makes about the potential functional impacts of prostate cancer treatment. It's a side of the conversation that we don't always hear enough about.
Yeah, it's a really crucial aspect that deserves much more attention. Treatments like surgery and radiotherapy, while often effective in treating the cancer, can sometimes have side effects that impact urinary bowel and sexual function. And the guidelines really emphasize the importance of addressing these issues openly and honestly with patients and providing them with the support they need to manage those potential challenges.
Right. So it's not just about treating the cancer, it's about supporting the whole person and helping them maintain their quality of life throughout their treatment journey and beyond.
Exactly. The goal is to achieve the best possible outcome for the patient, and that includes addressing their physical and emotional well-being, not just focusing on the disease itself.
I think that holistic approach is really encouraging to see. We've explored the complexities of prostate cancer care in the UK, delving into the latest guidelines, treatment options, and that crucial role of monitoring. But the journey doesn't end there. Join us for part 3, where we'll discuss ongoing research, emerging trends, and what the future might hold for prostate cancer care. Welcome back to the final part of our deep dive into the world of prostate cancer diagnosis and management in the UK. We've covered a lot of ground, haven't we? From those new, faster diagnosis standards to the evolving role of MRI and that growing emphasis on active surveillance and shared decision-making.
Absolutely. We've really seen a shift, I think, towards a more personalized and patient-centered approach, which is incredibly encouraging.
Yeah, and it's great to see. But as comprehensive as these guidelines are, they also acknowledge that there's still a lot to learn. And the future of prostate cancer care is likely to look quite different from what we see today. So let's talk a little bit about what's on the horizon. What are some of the areas of research that you find particularly exciting, and how might they impact patient care in the years to come?
Well, one area that's generating a lot of interest is the development of new biomarkers. That could really help us identify men at higher risk of developing those more aggressive forms of prostate cancer. Right now, we rely quite heavily on PSA testing and biopsy. But those methods aren't perfect. They can sometimes lead to overdiagnosis and overtreatment.
So the hope is that these new biomarkers could provide a more accurate assessment of a man's individual risk and therefore help avoid unnecessary interventions for those who are unlikely to benefit from them.
Exactly. If we can identify those men who are truly at high risk of developing aggressive disease, we can really focus our resources on providing them with timely and effective treatment while sparing others the potential harms of unnecessary interventions.
It's about really tailoring it much more to the individual.
It is. It's about moving towards a more precise and personalized approach to risk stratification.
Makes sense. What about on the treatment front? Are there any promising new therapies or approaches emerging that might offer patients more targeted and less invasive options?
Yeah, there's a lot of really exciting research happening in that area too. One approach that's gaining traction is focal therapy, which involves treating only the area of the prostate affected by cancer, sparing that healthy tissue. And this approach has the potential to minimize side effects, particularly urinary bowel and sexual dysfunction, which are major concerns for many men.
And that really ties back to that point that the guidelines emphasize so strongly about preserving quality of life for patients. So it's not just about treating the disease, it's about making sure the patient has the best possible outcome long term as well. Are there any other promising treatment advancements sort of on the horizon that we should be aware of?
Another area of really active research is immunotherapy, which harnesses the body's own immune system to fight those cancer cells. And while immunotherapy has shown a lot of promise in treating other types of cancer, its role in prostate cancer treatment is still evolving. There are lots of clinical trials underway to assess the effectiveness of various immunotherapy approaches for prostate cancer, and the early results are really quite encouraging.
So it seems like there's a lot to be hopeful for as this research continues. It's fascinating to see how research is constantly pushing those boundaries. But amidst all these advancements, one thing that remains constant is the critical role of early detection.
Absolutely. Early detection gives men more options and better chances of successful treatment. And these guidelines really emphasize the need for men to be aware of their risk factors and to discuss PSA testing with their GP at the appropriate age.
And to be proactive about their health in general.
Absolutely. To pay attention to any changes in their bodies and to seek medical advice if they have any concerns.
That's right. Knowledge is power. And the more informed men are about prostate cancer, the better equipped they'll be to make those decisions about their health. So we've really journeyed through this intricate landscape of prostate cancer care in the UK, from diagnosis to treatment and beyond. We've explored the latest guidelines, we've delved into the complexities of treatment decisions, and we've even glimpsed into the future of this ever-evolving field.
It's been a fascinating exploration, and I really hope our listeners have gained a deeper understanding of the challenges and opportunities in prostate cancer care today.
As we wrap up, I just want to remind our listeners that they are not alone on this journey. There are so many resources available, support networks to lean on, and a wealth of information to help guide them.
And with increased awareness, proactive healthcare choices, and the continued advancements in research and technology, I think we can really strive towards a future where prostate cancer is no longer a daunting diagnosis, but a manageable condition.
Thank you for joining us on this deep dive into the world of prostate cancer. We hope you found it informative, empowering, and perhaps even a bit inspiring.
Until next time, stay curious, stay informed, and stay engaged in your health journey.